Health disparities are difference in the incidence, prevalence, mortality, and burden of disease and other adverse health conditions among specific groups. These groups may be based on race or ethnicity, gender, education, socioeconomic status, or other criteria. Health disparities among ethnic minorities, the poor, and medically underserved are well documented. There are disparities for overall longevity measured by life expectancy and for specific chronic and acute diseases. Consequently, the prevalence of health disparities is ubiquitous and requires examination across the broadest possible range of health behaviors, risks, and outcomes.
We look at things from economic strain to vitamin D binding protein genotype in influencing outcome of vitamin D levels. So we can really span the gamut because they're each equally important. We've begun to look at things like sleep and deprivation of sleep in terms of trying to understand how that's related to stress, because trying to understand how stress influences health means you need to look at psychosocial factors as well as biologic factors. And the only context really in which to do that is within an interdisciplinary framework. We're trying to understand what are the transduction factors that change poverty into ill health. Understanding how those two things are related, as we know they are, has been one of the big questions that I've certainly been trying to understand.
I was interested in this area of research, particularly after doing my cardiology training and taking care of patients who had limited access to areas for physical activity and healthy nutrition. I was struck by how these barriers existed, particularly barriers that related to one's environment or to sociocultural factors related to health, but how little we understood about these barriers and how to intervene on them.
Health disparities is a broad and multidisciplinary field. Researchers in this area need a broad understanding of individual and group differences and the ways in which different health outcomes may manifest in different groups. Basic training in genetics is useful because increasingly we include genotypes in our analyses. Comprehension of statistical methodology, particularly longitudinal analysis, is useful, especially for independent investigators who want to initiate their own data interpretations.
A focus on reducing health disparities with the understanding that genomic technologies might facilitate that process. Social and behavioral scientists should be partnering with biomedical researchers in order to address the complexity of the problems that we're trying to solve.
Addiction is a behavior disorder, so partly it's within the individual, but also it's part of the environment that has a strong influence on whether people become drug users, whether they get well from being a drug user. And so we want to focus on the individual patient, but actually look beyond them to see what's going on in the rest of the world that could influence their drug-taking behavior.
Understanding behavior and how to change behavior, that is such a huge part of what we have to do. Understanding really the molecular basis, the biology behind health disparities, because there is truly a biology that we need to understand to be able to develop appropriate interventions and appropriate treatment strategies and even diagnostic strategies. I would say those are probably the two most important areas.
We've published a number of findings. Probably the most important general finding that we have is that there's no single cause for health disparities. Depending on the health outcome and depending on the specific predictors that we're looking at, different groups have different outcomes. It's not always disadvantaged groups that are stereotyped as disadvantaged that are the worst off. Sometimes upper income whites are the worst off. Sometimes low income African Americans are the worst off. It's depends specifically on the condition we're looking at.
One of the things that we found is that some of the places in the city of Baltimore, which is where we're located, is high physical disorder, but our participants are actually reporting that they feel more comfortable there, so more positive mood and less negative mood in some of the most disordered areas. And that's opposite of what we would have expected. And so I think that tells us that we have to look deeper and really study things and not just make assumptions about the nature of environments and how it influences behavior. It varies across different populations of people.
In our research, we have found that the neighborhood environment, particularly the neighborhood socioeconomic environment, plays a key role in the development of obesity, independent of one's individual level of socioeconomic status, meaning their individual income and education. We've also found that from a community standpoint, we can utilize cognitive interviewing in a group setting to tailor a survey instrument to the needs of that community.
Really, the field needs to move into developing interventions, primary prevention, trying to overcome the barriers of health literacy or the lack thereof in the population, as well as how do we train physicians to be more culturally proficient, because that's still part of the problem.
My epidemiology background allows me to understand how to analyze factors, particularly socioeconomic and psychosocial and environmental factors that relate to cardiovascular risk. And this public health background, in addition, helps me to understand or to provides the tools to look at interventions and design interventions to improve cardiovascular health.
It is our hope that better understanding the social environment and the built environment, that we can then target some of our interventions through community-based participatory interventions in these populations by working with the communities primarily in wards 5, 7, and 8 in Washington, D.C.
The consequences of health disparities are enormous and place huge burdens of poor health on people who often have the least resources to manage their chronic illnesses, their disabilities, and early mortality. In addition to helping resolve the personal burden of these conditions on individuals and on families and on co-workers, resolving health disparities will help relieve the healthcare system of costs that are associated with treating preventable diseases.